now what we aim for was quite a lot of time for discussion, because there are lots and lots of challenges, as you see. We may or may not be able to give the answers, but we would be very, very pleased if you would participate now, because it is a workshop. We want you to do some work and ask some questions or raise some points of discussion. Yes,
Can I start, Martin Myers? We're live with FIT at the moment. We're rolling it out for Lancashire, and the big debate we've had is the safety netting. And we're going to introduce, certainly for the first year, all FIT negatives to have a second sample. Because I'm not convinced that the stool is homogeneous for haemoglobin. So A, do you know whether it is or not? And secondly, the study, Sally, that you're doing and looking at 3 different methods of getting a patient to look at the same stool, are you convinced that the haemoglobin concentration is the same in different parts of the stool?
So, no, the haemoglobin concentration won't be the same in different parts of the stool. What is compelling is the evidence so far that suggests that if there is haemoglobin, if there is significant pathology, if there is cancer, then if you're measuring low enough, then it does tend to pick it up. Which would suggest that there is some haemoglobin in most parts of the stool, but I don't think we have the answer to that question. And I think I don't know if you want to comment.
Yeah, as you know, in Dundee, in the NHS side, we've been offering this since December 2015. In the first year, we did 5,500 FIT on patients referred from primary care. Half of these people did not get any further investigation. And so these are the negative people that you think really need some safety netting. We've followed those up by looking at the records for over the subsequent year, and the risk of having significant disease is tiny, absolutely tiny. So that yes, safety netting has to be in place, but as Nigel also mentioned, I think I've changed my view a bit over the years. I used to say fitter it and don't worry about the clinical side too much, but I think now we have to recognise that patients with iron deficiency anemia in particular, patients with really bad diarrhoea in particular, whatever their fecal haemoglobin, they probably should get referred for colonoscopy. So it's clinical plus haemoglobin, but if the haemoglobin is low and the clinical risk is low, certainly in our experience in Scotland, safety netting, yes, but you know, the amount of disease will be very, very low. And remember, colonoscopy misses people as well. Yes. Could you tell us who you are and where you come from?
I'm a consultant clinical pathologist in Bedford. Is there any cutoff for haemoglobin below which FIT should not be tested?
Is there any cutoff?
For haemoglobin, i.e. a patient who is anemic, they might have false negative result. I mean, do you have a cutoff for hemoglobin like 90 or 100?
I don't know the answer to that.
For blood haemoglobin, yeah, there are clinical guidelines for iron deficiency anemia from the BSG, which define the criteria.
My question is different. My question is, for example, we don't use HbA1c for diagnostic purposes for diabetes if hemoglobin under 90, for example.
So I think once
do you have a cutoff? You would
so
say you should.
We haven't operationalised that yet. I know in Nottingham they have, and what they do is if patients are anemic, they still test them with FIT, but if it's negative, they still process them as a normal clinical referral. However, if their fecal hemoglobin is above 150, then they expedite that patient faster.
Yes, so it's again a combination of full blood count, clinical impressions, risk of symptoms, and the fecal hemoglobin. It's a multifactorial decision, isn't it?
Yeah.
Yes, Ian.
We've operating with FIT, and we've put an extra step in there. I'm not sure it's right or wrong, but it's as a referral, you could refer for a colonoscopy, but you may not actually get a colonoscopy. You may end up with an outpatient appointment where they actually look at the symptoms as well as the FIT result. So they're using FIT as a kind of a referral tool for an outpatient appointment, and at that point they'll look at the result with the symptoms and then
Well, see, for me, that's the really interesting thing, because a lot of people are worried that FIT will then become this tool which overrules all clinical judgment, but I completely disagree. I think what FIT will do is return power to the clinicians, where you don't have to see all these patients in the two-way pathway. You can see them in clinic and make a judgment based on symptoms, rather than just doing colonoscopy saying, you don't have bowel cancer, refer back if you still have symptoms in 3 months' time.
So I think what started off as a black and white thing of, it's positive or negative, colonoscopy or not, there's actually this area in the middle that we can target.
Yeah, because as you know, our referrals are all viewed by consultant gastroenterologists who take what the GP put into the data system and the fecal hemoglobin and age and other factors and the full blood count. And so they like, in your setting, it's not just fit, go for it or not go for it. It's a much more integrated clinical decision. And if you guys, as clinical biochemists and chemical pathologists, are thinking of introducing this, I think both Ian's experience and our experiences, it has to be seriously multidisciplinary with laboratories, the endoscopists, gastroenterologists, surgeons and so on to make this work properly. Very, very important.
We are evaluating the manufacturer's advice, and they suggest a cutoff of 50 for positive. Now, your guidelines, should we apply your guidelines? Is there a risk in using manufacturers versus an externally suggested guideline?
Which manufacturer?
It's their product. I'm from Canada.
Yeah, well, probably, is that 50 nanograms per mil?
Right.
Or is it 50 micrograms?
It's 50 nanograms.
Yeah, so that again is an important point, and you'll find a lot of the literature is it reports the fecal hemoglobin as nanograms of hemoglobin per mil of buffer in these tubes, and that is absolutely wrong, and you should only use micrograms of hemoglobin per gram of feces. So in these cases, 50 is equal to 10. It's exactly the same as we use.
Right.
So the Canadian provinces have different cut-off points for screening, but for the symptomatic, it's quite clear that the evidence is that the cut-off should be really, really low, and your 50 is really 10. So 10 is analytically achievable with good performance characteristics.
Probably on clinical catering. Our area is joining on to the Leicester work that's been done because we sort of just want to start small and kind of, join with those that have got the experience. When you put up one of the earlier slides with the updated NICE guidance on, it seems to be saying that it's really those that don't meet the referral criteria that are suitable to do a fit in. Whereas it seems to me, listening to the discussion and from what I know at Leicester, it's those who are going to be referred anyway that get the fit as sort of part of the referral pathway. And there seems to be a hesitance to widen it out to anybody who wouldn't be referred anyway.
Right.
But I open that out to anybody, and maybe I'm wrong with my impression.
No, I think Ian ourselves, and people with lots of experience, would say everybody, and low risk, high risk. As Nigel's shown you some of his data, there are differences, but there are a lot of similarities as well. So DG30, as you know, when you look at the evidence base for the recommendation, it's actually very, very small, because it's surprising that we can go from the first paper, which was in 2012, to a national guideline in 2005 years to translate from a wee research project to routine in the NHS. Is amazing, but it's not huge evidence base, and that's what Nigel and Ian and ourselves and so on, we are collecting data. So I think that over the next few years, and people like Martin as well, of course, will provide good quality publications and provide some solutions to the many, many challenges that we still have. And on that note, I'm afraid time is up. So thank you very much indeed to Sally and Nigel and yourself. And if you haven't signed anything, you can please sign the paper. That's Thank you very much.